couple of months ago, Mariela contacted me at the Meuhedet HMO to see if we have interest in taking part in this conference. Although low-carb and ketogenic diet are not a mainstream treatment of metabolic disease, we decided to go ahead and support the event. And in part, it's related to my personal story as a family physician. I graduated from medical school about 20 years ago with no nutrition study at all. I decided to specialize in family medicine, and when I started my practice, the reality I was facing is that nutrition was a key component in my patient morbidity. Yet, I had no tool to deal with this situation. I decided to go back and study nutrition for 2 more years, and when I graduated, I felt I didn't receive any more additional tools, but the notion that we have no real understanding of the situation. In the recent year, more and more, my patient and others come to the therapist with questions about low-carb diet, interaction with drugs, and clinical condition. Due to our lack of knowledge and experience with this diet, many times we have no answer, and when we review the literature, we encounter lack of information and a lot of controversies. In this panel, we will deal with some of the question and try to give them answer or leave them with the uncertainty and hope that in the coming years, the research will shed light on some new information. And we will begin, and I will ask the panelists to briefly introduce themselves.
Hello everyone, my name is Ivar Cummins, aka the Fat Emperor, and and I've been an agent provocateur for some time. But no, I work as Chief Programme Officer for Irish Heart Disease Awareness, that's ihda.ie, and we promote the calcification scan to discover the most at risk for heart disease. I also have a podcast and a book with Dr. Jeffrey Gerber, they're my disclosures, and I focus on insulin resistance, metabolic health, cholesterol metabolism, and what are the most important items and the most important nutrition to deal with our modern epidemic of diabetes and obesity primarily.
Thank you. I'm Steve, and I'm a recovering academic. By which I mean I'm a professor emeritus of internal medicine. I had specialized in clinical nutrition, but once I freed myself of the bonds of academia, I found it possible to do much more creative research, and the last 20 years has been probably the most fruitful in my life, leading up to the formation of Virta Health, which is a research-based program to assess how we can reverse not just thousands but millions of cases of type 2 diabetes.
Hello, my name is Rudy Fink. I'm a clinical dietitian specializing in diabetes, a podcaster and YouTuber, podcasting and YouTubing about low carb, intermittent fasting, keto. That's it.
Hi, good afternoon. My name is Dana Weiner, and I'm the head dietitian at Chiba Medical Center. I have over 80 dietitians, and some of them do practice keto diet in sick patients, oncology, and of course, neurology. My specialty is nephrology, and so I did treat a lot of patients with diabetes throughout the years. And I just realized that I may be the keto Grinch here, so I hope I won't get anyone upset.
You're not alone. So, my name is Eldor. I'm the director of the diabetes unit in Tel Aviv Sourasky Medical Center. I think that's enough for now.
I'm Ilana Harman. I'm an internist diabetologist that was head of diabetes and internal medicine at Soroka for 42 years. That's in Be'er Sheva. And I'm now down in the community doing clinical diabetology. And I'm actually here, I think, as a representative of a lot of Israeli HCPs who are very sadly not sufficiently literate in nutrition. So we follow our dietitians almost blindly.
So thank you, and we will start. This was one of my patients, pre-diabetics, 35 years, no medication. He started the keto diet, and as you see, before the keto diet is a lipid panel. The triglyceride is 240, LDL was 160. 2 months after starting ketogenic diet, the triglyceride the level was falling, 140, but the LDL cholesterol was higher, 194. So what is your recommendation for this patient?
There are missing data. What about his weight? What happened to his pre-diabetes state during this?
He was overweight. He was pre-diabetes.
Did he lose weight in these 2 months?
Yes, he was losing weight. All the other parameter was good. The inflammation was coming down. He was
Family history of
no.
of anything. Okay. My guess is just, as a dietitian, of course, is to just keep on following, because we know it can happen in the start of the diet, maybe to check if he's doing it the right way, of course, and to just go along and figure out if it's going up, and if it's not helping him, losing his weight or managing his pre-diabetes state, then we could change to another diet, maybe.
Okay.
So if I have to choose with regards to evidence-based medicine between LDL and everything else you said, inflammation, weight, I don't know, whatever you want, okay? I'd probably choose LDL, okay? Because few biomarkers have more merit to them than LDL cholesterol in 2019. Now, that said, I wouldn't necessarily tell him to stop a diet that he loves doing and he's having the time of his life, but I might offer him a statin if he's so much at risk with this kind of LDL. And that's the main thing that's disturbing me. But if I have to choose this or that, LDL is much stronger, much more evidence-based than anything else we currently have with regards to a therapeutic option also as a therapeutic goal.
Okay, I'm going to take acceptance to that. I think even the European Society of Cardiology guidelines have finally come to the nitty-gritty, and the point is assess the risk. So this is a young man with no other metabolic syndrome components whatsoever. He's not hypertensive. He has no family history. He has no he's pre-diabetic. He's not diabetic. He's obese, and he's losing weight on his diet.
And he's feeling
so
good.
He would want to
he's
be,
feeling good.
And his diabetic lipid profile has improved significantly. So you're left with pure LDL. So you now have tools that you can use every day in Israel. We're blessed with that. You can look at his ApoB, you can look at his Lp(a), and the calcium score guys are here. You can ask that question, but would you do that routinely in a 34-year-old patient like this? I'm not so sure. It's not available, and it's not in a basket, and it's expensive. Okay, so you would assess the risk, discuss this, okay, and follow it. I would follow it at this point, and I'm very LDL-minded, and I'm quick to pull out the statins. So that I think if I had to choose, if I didn't have any more information whatsoever, then I would have the discussion and probably put him on a statin. But, I'd like to leave the but hanging out there.
I think it's pretty agreeable that in this state it's smart to continue with the low-carb diet. But if he doesn't improve his LDL, because all the other markers are obviously better, if he doesn't improve his LDL, I don't think the first option should be getting him out of the diet. I think it's modifying the diet to try to lower his LDL without getting out of his low-carb diet, because he has good results otherwise. And only if this doesn't help, starting to think maybe a bit, sometimes adding different carbs or a higher amount of carbs, but again, from vegetables, not something starchy or something like that. This is what I would do.
I love this question. Because I had this question about 35 years ago when I saw repeatedly that when we start people on a ketogenic diet and they lose weight rapidly at the start, that LDL, the calculated, by the way, this is not directly measured, this is a calculated value from the Friedman equation, but LDL cholesterol would go up. And in some of my patients, the more weight they lost, the result became extreme. I had patients go to 400, and I didn't know what that meant. Until someone pointed out to me that we humans store free cholesterol, not esterified cholesterol, in our adipose triglyceride. And it's not highly soluble. If it's esterified, it's very soluble on triglyceride. If it's free, it's low solubility. And it's about 1.5 milligrams of cholesterol per gram of triglyceride. You don't want to know all this detail, I apologize, but I love detail. When you lose 100 grams of triglyceride per day, you mobilize 150 milligrams of pre-existing cholesterol into your circulation. It has to leave the fat cell or it will crystallize. I always thought that reverse transport would be HDL, and yes, HDL is going up, but what we saw mostly was a rise in LDL cholesterol. So we actually did studies in people prospectively where we did adipose biopsies to look at the cholesterol content across 40 pounds or about 20 kilos of weight loss. And people let us do the adipose biopsies because we called it mini liposuction. But we only took out about 100 milligrams of, and what we saw was that adipose free cholesterol went up slightly at the first 20 pounds of weight loss, and then it plateaued and stayed stable, which means they were mobilizing it. But predictably, when people stop losing weight, the LDL comes back down in almost all of them. So it's a transient effect. We published a paper in 1991, American Journal of Clinical Nutrition. It's called, we titled it the hypercholesterolemia of major weight loss. And in most patients, it self-resolves in the first 6 to 9 months once they plateau at a new steady state. There are some people who do remain high long-term, and if it's threateningly high and it's a concern, I have no inhibition to adding a statin to that. And Jeff Volek did a study, which he published, where they took patients who were on a statin and put them on a ketogenic diet, and the LDL, or the statin, continued to work very well, and then we saw the triglycerides and HDL go up. So the two are very effectively compatible together if necessary.
But how do you know it doesn't mean anything? I mean, you're giving them a high LDL diet, okay, a high LDL, serum LDL diet for, let's say, a year or half a year until they plateau, or maybe a year and a half until they stop dieting. And how do you know that doesn't build atherosclerosis? Because the effect of the anti-LDL drugs is fairly, in a year you do see already an effect of these drugs by reducing the LDL. So how do you know that you're not building atherosclerosis in a year and a half of high LDL or half a year of high LDL?
Okay, well, I'll let you answer that in a second, Steve. So just for my point of view, so I look at that and I'm inferring the total cholesterol with the trig down, the HDL up, and the LDL with its move at 30 or so. And I suspect on MESA calculator, and I love that point about the risk calculators, everyone should be using the risk calculators. I'd suspect that guy, especially if his hypertension reduced, will now be lower 10-year risk in the MESA risk calculator. So his vector will have been positive in terms of lower risk in a diabetic sense, but in a general risk algorithm sense. So I'm going to talk about this in my talk tomorrow. So if I would hold with that person, 35 is a little young for a calcium scan. Now there are studies on people 35 to 42, and a high score is still 15 times the risk of a future event of a low score. So it works, but very few people do have a score. So it's not very efficient to scan people unless they have a strong family history. But I would hold the fort for 6 months there, look at the dynamic of where the LDL goes, and keep checking in on those risk algorithms.
Well, we saw this morning the one slide of the direct Iris Shai's work from Kamag, which is now out. She's already published 4-year data. Okay, and there's a regression, 15% regression in carotid plaque volume with a low carb and a Mediterranean diet, if you maintain the weight loss. So, it's associated with the weight loss and the reduction in insulin resistance.
Yes, but we know that we have 20% of hyper-responsive people that the LDL will go high.
Fine.
So,
but again, you take a
Yes.
population, you follow it along in a rigorously controlled trial, and you still get a positive result, but mainly with the Mediterranean diet, low carb, less with the low-fat diet. It is associated with the weight loss and the decrease in HOMA-IR. And the maintenance of weight loss, which is best in the Mediterranean diet.
That's another question because I've been here for most of the day and I've heard most of the research, and you keep comparing the low-carb diet to the low-fat diet. And in Iris Shai's research, most of this was low-fat diet. She used the Mediterranean diet, which is not low-carb diet, as we all well know. And we saw some very great results with the Mediterranean diet. And again, I ask, if the patient has a LDL not of 194, of 400, and you consider giving him a statin with all the side effects that we know, why not change the diet?
I want to answer dietetically too. This is the idea of modifying the diet. Why not combine both holy grails together of Iris Shai's research? Why not do a ketogenic diet which takes from Mediterranean, like a lot of olive oil, a lot of nuts, seeds, fish, dairy, but and a little bit less like meat and veggies. This type of diet can modify the LDL. I agree with you completely that we should change that if it continues, because we have only 2 months of data.
I'm sorry, we're in the no hard outcome zone with this guy. And the risk calculators don't really predict the risk for this guy, right, for him. No, I'm talking about your patient. Not generally, you might have a 10%, 5%, doesn't matter to him, right? And if you think about the, because we don't know if the ketogenic diet changes the risk. Maybe it increases the risk. We don't know. That's why I'm saying we're in the non-hard outcome zone of medicine. And when you're in that place, most of the day we are at that place with many of our patients, of all these things, really, LDL, that's like the strongest predictor, the strongest point of, not predictor, but the strongest point of interference from a physician to change the outcome of a patient. Anything else I do, triglycerides, we tried, didn't really do anything, right? HDL, a big flop. Want to continue? I mean...
So on behalf of the millions of people, countless millions of people out there, you didn't hear what I have to say yet, who get medicated or not based on the 5 world's main risk algorithms. They all agree with each other. 40 years of actuaries, physiologists have done work to get these algorithms very good, and they don't use LDL. So the risk algorithms use the total and the HDL. And the reason they use that is because the ratios are what predict, not LDL. It does not predict worth a damn. And Castelli, the head of Framingham Research, the longest heart study ever run, in 1996, he publicly published a paper and said unless the LDL exceeds 300 milligrams, right, on its own, it has no predictive power. So the risk algorithms all over the world use the ratios, and the reason they are powerful is because they are proxies for insulin resistance. The risk calculators are not cholesterol risk calculators, the existing ones. They're effectively insulin resistance.
They're not, the only intervention which changed mortality and morbidity. The only hard outcomes we have are with LDL cholesterol lowering drugs, no matter which mechanism you use. So that's the hard truth, okay? Now, the risk calculator, I agree, if the HDL is low, if the triglyceride, we know that, okay? But still, for us to intervene as an intervention, the only hard place we can intervene that has proof beyond any doubt is LDL. So to me, LDL is the place I want to go. High LDL I can lower and I can reduce risk. You're doing something that's increasing LDL proactively, okay? This guy gets a heart attack in a year and a half, he's going to sue you and says, you caused my LDL to go up, and all the data is against that. What are you doing against that?
Let me add a little data that maybe has been hidden in plain, well, it's been hidden since a year ago, and that is we published the one-year data from the study we're doing with Dr. Sarah Hallberg on patients with type 2 diabetes, reversing it with a well-formulated ketogenic diet. We recruited 262 patients, and at 1 year we had, I think, 210 of them still in the study. We did carotid ultrasounds on people at baseline and at 1 year, and that's an awfully short period of time. But what for atherogenesis, because it takes decades in most patients for atherogenesis to become clinically apparent. But what we did was we segmented the patients into 4 groups based on their LDL response. Some people went down a lot, some people went down a little, some went up a little bit, some of them went up a lot. We looked at the quartile that had the greatest rise in LDL cholesterol, and there was no change in carotid intramedia thickness at 1 year. We've completed doing the 2-year data, and we're analyzing that now, so we will publish that data as soon as we have it.
Sorry, I have to answer that also. A 1-year study with diabetics, I want a look-ahead study, a 9-year study.
Well, wait 9 years and we'll have the data for you. I'm sorry.
Because that is what you really need to prove a point in this disease. I mean, a 1-year study, you can really prove anything. Any diet will work for 1 year with diabetics, and you call it reverse or cure, I call it maybe control, because they're not cured. We know that. They're never cured, okay?
I never use the term cured, by the way. We use the term reverse because it's a dynamic. It's not a destination, it's a process.
Okay, I call it controlled, so the patient knows he's still diabetic. But the thing is that, basing decisions on 1 year data may be dangerous, because if you look at the look-ahead data, it didn't predict anything. It predicted that it doesn't do anything. So you're talking about the maintenance, the ones who maintained their weight loss. So if you see a benefit with the ones who maintain the weight loss, what happens to the ones who didn't maintain? Does it harm? And how do you know in advance who's going to maintain and who's going to not maintain it? It might be a harmful intervention. So that's it.
So thank you. This is we see that we have still a controversy, and I think that there is still missing data. We have to wait to see the results of the research, and we have a surprise because everything we have a surprise with our patient. I didn't know that he also has a gout in his past. He didn't tell me. And we saw that his uric acid rose from 6 mg to deciliter to 8 milligram to deciliter. And what we are going to do with him now.
I just had a comment before the uric acid rise. At the end of the day, when we talk about evidence, the truth, even if it's painful, is still the truth. The data as it exists today, longitudinal data, is about LDL. It's not as strong as everybody thinks it is, but it's quite significant. You can't argue with that. Now, insulin sensitization, the risk scores do predict insulin resistance or insulin sensitivity, however you want to call it. But all the studies until now, except for physical activity, which is a bit different, all the medical interventions to insulin-sensitized patients didn't really show that kind of a benefit on cardiac or total mortality, by the way, just to prevent the diabetes, not the other outcomes. So as far as medicine goes today, insulin sensitization, as far as exercise, is amazing, but giving metformin to everybody to make them more sensitive is probably not that efficient and doesn't work. So LDL does have evidence. It's not as strong as everybody thinks. We talked about that before. The number needed to treat to prevent an event is huge and more side effects probably than everybody knows. But the data is the data at the end of the day. You can't argue with the data. That's the data.
Great discussion. I've heard this discussion before. The keto diet reduces cardiometabolic risk by addressing the metabolic syndrome.
You do not know that it translates into hard outcomes. You do not know that the ketogenic diet doesn't increase the risk of death, hard outcomes like MI or stroke. You don't know that the keto diet doesn't increase the risk of ketoacidosis in patients who are more prone to it. You don't know any of that, and you're recommending a treatment.
Doctor,
you would not
please.
give a pill which was examined for from a one-year study, but you're giving a keto diet which, you can argue if it's even been through that rigorously.
I tried to bring you through 20 years of my experience.
Experience is not hard outcome, okay? We need
Can I
studies.
have 1 minute? This is fun. I haven't had this discussion in a long time in the States. LDL is not in the risk calculator, I think is what Ivor was trying to say. And actually, Ivor Shai here in your own country showed regression of carotid thickness, and that was what you were trying to say, and you didn't hear it, Doctor.
Yeah,
Please
have you heard of rosiglitazone?
Please,
Reducing
please.
carotid intermediate thickness?
I'm not a medication doctor, I'm a diet doctor. The keto diet, so in the absence of evidence, it might even do better. Why do you fear? Why do you fear? So if I have a choice of fixing diabetes in the patient in front of me, or worrying about an LDL elevation of 3 or 30 or whatever it is, I'm going to fix the diabetes. That is a risk equivalent. You don't agree, doctor, that
No,
you
I
have a choice?
The diabetologists amongst us have been through rosiglitazone, which was a beautiful drug.
No, that's not my question.
Wait, let me finish. That reduced carotid intermediate thickness, and a few weeks later, after that paper came out, a few weeks later, came out a meta-analysis suggesting it increases cardiovascular morbidity, okay? So that's why we need, which was recanted eventually, but we need hard outcome data. We can't speculate with a disease we don't understand. We don't understand the mechanism of this. We don't understand why it happens to everybody. We don't understand how to cure it. And we have to base our decisions very humbly on hard data and not speculate.
So if you had a choice in the patient in front of you to reduce their cardiac risk, would you take away their diabetes or leave them with, take away their diabetes, yes, leave their LDL up 30 points, or would you treat their LDL 30 points and have them have diabetes?
Until 2015, if I had to give my diabetic patient one drug to take to
well, that's a different question.
Desolate island, choose one drug, he'd take a statin, not a drug for
not to fix the diabetes.
After 2015, we can talk about that, because we have a few drugs.
I totally disagree. I would want to fix the diabetes in the patient in front of me and let the LDL go up.
Without any evidence to do that, sorry.
All right, no, diabetes isn't the risk calculator. It's oh, my goodness.
I have to, I have to answer. I have to answer to you, because the Uric research was not keto diet. It was more a very modest Atkins diet, a low-carb diet. And the Mediterranean diet showed us the same results. Some of them were better and for a long period of time. I do not recommend, because I'm a dietitian, I do not recommend patients to take medicine and drugs. But if I have a choice, and I'm doing it for more than 20 years, and I managed to take care of my diabetic patients or kidney patients, with a different diet, not just a low-carb diet. And actually, when you're talking about low-carb diet, we didn't give him the high-fat. I never used the high-carb diet. we already used to lower down the carbs to our patient, and not just sugar, of course, also everything else. And I managed to take care of my patients very, very well without the uric acid and without the LDL and without all the things. And I don't think we failed in this. I think that we can use the keto diet or the low-carb diet as another tool to treat our patients when it's suitable for the patients, when it's suitable for their risk, and when it's suitable for him to maintain on this diet, because it's not a very easy diet to maintain. So I do believe in diets more than statins, so I would recommend him to starve on the island. But otherwise, I don't see why it has to be one diet. I think that in this era of time, talking about personalized medicine, giving everyone the same diet, it doesn't matter which one, is wrong, is simply wrong. And we should adapt to our patient, and we should listen to our patients to see if he can eat it. I won't be able, I wish I could do a keto diet, but I won't do it. But some of the patients won't do it either. So recommendations and research are great, but we have to translate that to the patient, and it's not as easy as you think.
I'd just like to say, isn't it quite fascinating, really, that we have spent 50 years and hundreds of millions of dollars on low-fat diets, beating our heads against the wall and getting bugger-all outcome data. So we've actually squandered 50 years and $1 trillion+ on the wrong thing. Isn't it fascinating that now in the past 5 or 10 years, there's an explosion of data that addresses eminently and fantastically the primary factors in the risk algorithms, right? And yet we don't have the outcomes data because we squandered 50 years. So I think I can understand the, frustration of the people that all the inductive and deductive reasoning, science, metabolic science, and every strand of this points in one direction, but we squandered the chance to have the outcomes data.
But we do have some hard data, sorry. No, so we do have one study, which is called the lookahead study, right, which has some hard outcome data. Not about keto diets generally. And that was a well-conducted, no, it's not a well-conducted study, long-term cardiovascular outcome study. Okay, it failed, exactly.
Yes,
that's the data we have. It didn't work, okay? So when I say, if the diet my patients get is not a weight-losing diet, because there's no evidence for weight-losing diet in diabetes on the long term. They get a low glycemic index diet. Excuse me, they get a low glycemic index diet, which is similar to a low carb, but not extreme, doesn't raise LDL, because it's easier to control their diabetes on a day-to-day basis that way. But for weight-losing diets, I mean, there's still, we don't have any evidence for that. We don't have evidence that the ketogenic diet will not look like a look-ahead study if it's conducted ever. Okay,
This is the first time I've ever heard anybody claim that the look-ahead study had anything to do with nutritional ketosis. It was a very, very intensive intervention with a healthy but high carbohydrate diet, and you can't draw conclusions about nutritional ketosis from that any more than you can figure, that you can throw a stone from here to Italy and you hear a splash, Italy's not there. And so I would hesitate to try to draw any conclusions from the fact that the look-ahead study didn't do what a ketogenic diet can do. Nutritional ketosis is a unique and very powerful metabolic state. I will present data tomorrow showing that it dramatically reduces a host of inflammation, what people call inflammation biomarkers, which are really cytokine, chemokine, and adhesion molecules that are mediators of tissue damage, and they come down. So we have other indications of what's occurring in this process, but Dr. Westman said very well that what we're doing is we're reversing essentially all the known components of metabolic syndrome and type 2 diabetes with this, including the underlying inflammation that's now understood to be a driver of it. So I would say we should exercise a certain amount of clinical wisdom in trying to assess the interests and the needs of an individual patient rather than trying to treat that individual as a representative of a large cohort. Yes.
I'd like to say something about that. I thought that the lookahead wasn't entirely a negative study because the people who lost more than 10% of their weight actually went into diabetes remission as a function of the number of times over time that they actually achieved normal glycemia. So what I'm trying to say, and it comes back to what you said and what you just said, okay, there's more than one way to skin a cat. And we don't know, and individualizing it is something that we're going to have to be learning about and finding the hard evidence for before we make final decisions, definitely on a public health basis.
But I have to answer you, sorry. The lookahead did not talk about ketogenic diets, but it taught me, okay, to be a little more humble when I assume things based on small, short-lasting studies. Because if you look at data from the diets that were done in the look ahead, they have a lot of data to back them up as reversing diabetes and stuff like that, because we know that every weight-losing program, Iris Shai told us that already, will probably benefit diabetes on the short term. But on the long term, we don't have the data. It was a negative study. And moreover, when you have a subgroup in a study which benefits, what does that mean about the subgroup in the study which didn't lose 10%? Did they have harm? I mean, I'd assume if the relative risk is 1, they probably are harmed by it. How do you know if your patient today will lose 10% on the long term or lose only 5, gain weight, and maybe suffer from this intervention? And that's the problem with this. And we have, the scrutiny of a diet should be the same as the scrutiny of medication. The same as a pill I give has to go through a cardiovascular outcome study on thousands of patients for a long-term evidence to be generated. The same thing has to happen with the diet that I recommend, because it's a medical intervention. Okay, it's not, diets don't get a pass-through jail free card. Okay.
Well, just on that point, and you heard Zoe Harcombe this morning, presumably. So we foisted a diet, a medical intervention on the whole world with effectively no evidence that now after 50 years we're running away from in panic. Let's be honest about it. So to say that it's a medical intervention an intervention you can't do, if it's species appropriate and lines up with all the mechanistic data, evolutionary data, and everything else, does it need an RCT with a placebo? Okay, so
what causes diabetes? You can't assume anything in this disease.
And what about Virta? What about Virta then? Standard of care for diabetes, generally speaking, is there's no remission with the standard diets, and if anything, there's progression. And Virta got 60% remission effectively, and 94%.
We never say remission. We say
sorry.
Control.
My word. Apologies. My word. Reversal, or some other word meaning it has mitigated or abated down to below 6.5% A1C. But 94% lowered or eliminated the medication under medical, supervision, and there was a 12% weight loss. I mean, what does that mean to you when the standard of care diet and medication does nothing or less than nothing in a calendar year? How would that strike you as a technical person?
Medication has actually a lot of evidence, long-term evidence, to reverse or cure diabetes if you assume that a cure or reversal is below 6.5. You have the DeFranzo study going on already 6 years showing that. There was a recent study in the ESD published that you start with multiple medications, you actually can maintain the patients very well controlled for a long time, okay? Much longer than any diet has ever shown on the long term, and this is the whole cohort, not the subgroup which maintained the less than 10% weight loss, okay?
But diet, not medication.
Now with the new medication that we have, you're also going to get significant weight loss, okay? So and apparently being human means it's much easier to take a pill than to go on a diet. That's the evidence that we have today.
Well,
No, wait, now I'm opposed. I have to say something. We are talking about diets all the time, and I think that we are aiming to something else, which is a way of living or a lifestyle, and that's a major difference. Because using a keto diet as a mean to lose weight as a short period of time, I don't know how short. With the research that we have, it's only 2 years, so maybe not more than that, with not doing any harm, which is also questionable. And doing, it's not a diet, and we don't use this term anymore because we don't give only diet. We use everything. We use physical activity, we use stress management. The theme of, if we're talking only about losing weight, diet is a mean, it's a way to get there, but it's not everything. And I have to tell you, I don't know if you read, there's a book, a very good book that came out this year, which is called Deep Medicine. And there is a whole chapter on nutrition and research on nutrition. You are absolutely right about that. The research in nutrition is poorly conducted most of the times, and the information is very confusing. And to think all the time that we are eating only carbs or only fat or only proteins is wrong, because we eat thousands of molecules that can affect the way that you or I can, respond to a certain diet. And that's why we cannot give everyone a keto diet or a Mediterranean diet or other diets. It's very, very personalized. And I think that if you were familiar, just a few month ago, there was research done from Sheba on a molecule that they put as an additive in food, very famous additive that we eat in a keto diet, of course, which can affect insulin resistance, and it's only one molecule that affects in food, it's a food additive, and we do not address it at all. We just look at the macromolecules, and we have to look deeper, because nutrition is much more smarter than protein, carbs, or fat.
I agree with all of that, of course. I'm not sure that was even being contested. So we've actually written a book about it, and it includes all the vitamins, minerals, sun, sleep, stress, everything else, and the diet. So I absolutely agree with everything you said. Not sure about the last molecule. But we were talking about the best diet, and the best diet is individualized. For me, the best diet for an individual is one which minimizes risk, which means it best addresses the largest risk factors. Now, I know we differ on LDL. That's why I use the algorithms generally, or advanced inflammatory markers with great science behind them. But you, of course, will find people who in a keto diet, and there are rare people where their triglyceride over HDL goes the wrong way completely. So I don't argue in the slightest about individualization, and it might not be for everyone. But I think when around 75% of adult Americans are now essentially diabetic, you've got an elephant in your room. And the keto low carb is the best weapon to take out the elephant. So on a Pareto principle, it is going to be a very dominant diet approach in our modern world, not exclusive.
Not evidence.
Yes, so you think that oxidants are bad, or the oxidative stress is bad in diabetes or prediabetes or metabolic syndrome?
It's a huge issue.
It's terrible, right?
Enormous.
Vitamin E is a great antioxidant, right? So what happens there?
It doesn't work.
How come? Right. So why doesn't it work? If it's the strongest antioxidant doesn't work in a large controlled study, maybe we don't understand the disease, and enough of this hubris that we assume that a rat model can tell us anything about the most common human disease. There is hard human evidence to say things.
Just on vitamin E, the vitamin E trials failed, but vitamin E did not move the markers, so it failed. I'm talking about dietary interventions that do move the vectors. If something doesn't move the vector or the marker, I agree, what's the point?
They move the biomarkers that have not been proven clinically in an interventional trial except LDL. That's what they've been proven. LDL, blood pressure, glucose. Those are the main biomarkers that you can talk about that have been proven with pharmaceutical interventions, actually, okay? Not with diet. So.
Thank you. That's wonderful. And so going back, I just have to say, my nickname was Mr. Randomized Controlled Trial in training. In fact, I got kicked out, pushed down the road from a training center because I was asking, where's the data? Where's the randomized trial? I can talk randomized trials. There was, and correct me if I'm wrong, and I will pay 100 shekel to anyone who can find me the randomized trial that showed the current treatment of diabetes is better than the traditional treatment, which I showed on the slide from the Osler test.
Tempereg, leader, should I continue? Declare, should I continue?
Can I
We've been, you know, we have a multitude of hard outcomes recently in diabetes.
Tell me, excuse me, sir. Show me the randomized trial. Show me the randomized trial, randomized controlled trial that proved that your current endocrinology treatment of diabetes is superior to the low-carb, high-fat diet from 1923. I showed that, well, there is no study. There is no study. How can you say yours is better?
Oh, I didn't say that. I didn't say that.
Oh.
I'm saying, excuse me, you have to understand what we're saying.
How can you be afraid
I'm
of
saying you have to treat based on evidence, okay?
So wait a minute.
You don't have evidence that your intervention does anything.
This is a total double standard.
No.
If you ask me where my data is, I ask you where your data is.
My data has... You don't have hard evidence for any dietary intervention. You don't have a CV outcome showing reduced mortality. I have a CV outcome showing reduced mortality with empagliflozin. I have a CV outcome showing reduced mortality with liraglutide. You don't have any of that, okay? So you're saying don't give him drugs, give him a keto diet? Okay, that wouldn't hold for scrutiny anyway.
I think
Before we will continue, thank you.
I just had a comment about the inflammation markers. Basically, I think Iris Scheid showed that very well. Most of the CRP, which we measure, ferritin, things like that, are derived from fat. So if you lose body weight, inflammation goes away regardless of the diet you choose. It can be keto diet, it can be Mediterranean diet. Inflammation will go away equally. So if you lose a certain amount of kilograms or percent body fat, the inflammatory marker is not because of the keto diet, it's because of the weight loss. And weight loss can be achieved in many ways. So hanging your hat just on inflammation on keto is not substantiated by the data.
Yeah, I didn't say CRP specifically, like LPPLA2 and endothelial stress, oxidative stress markers, and all of those. They are not just driven by weight. You can have an insulin-sensitive 45 BMI guy, and I have the studies who are insulin-sensitive with no inflammatory markers at 45 BMI. You can also have a person at 22 BMI with enormous inflammation. So the weight doesn't drive it. Dysfunctional adipose cells drive the problem. So that's just a distinction, in fairness.
Okay, we will continue to the gout issue.
Who's the patient?
We're discussing uric acid now, is that correct?
Yes.
Yeah.
Again, something that I hate to claim age here, but I was alarmed by this in the late 1970s in my first study when we put people on a ketogenic diet in a metabolic ward, and it was not high protein, it didn't have a lot of organ meat, so they weren't getting lots of purines in their diet. It wasn't a high purine intake. And in the first week, uric acid level in otherwise obese but otherwise healthy people doubled. And from about, in our unit, 6 to 12. And by the end of 6 weeks, it had come 80% of the way back down to the baseline value, eating the same foods. And I was puzzled by that, and I talked to some people who had trained with George Cahill at the Joslin in Boston, and they told me that this is a normal finding even in total fasting, and the reason it goes up is that beta-hydroxybutyrate is an organic acid and competes with uric acid for excretion in the organic acid secretory pathway in the kidney. And what we've observed over time is it takes 3 to 4 months of maintaining nutritional ketosis and maintaining the same food intake that uric acid comes down to and then below baseline. And in our Virta study at 1 year and 2 years, uric acid level actually goes below their baseline value. So again, it's a transient effect, and it takes a matter of a number of months for the body to adapt to this different metabolic circumstance, and the kidney is able to adapt and adequately clear uric acid over time. For somebody with a history of gout, well, we talk to the patient individually and we offer them allopurinol, a uric agent, beforehand, and then keep them on it for a couple months of the diet. But then we also say, but a very small percentage of people with a history of gout actually have a gout attack where we start a ketogenic diet. And so we offer them rather to have a prescription handy for their favorite anti-inflammatory, be it ibuprofen or colchicine or whatever, have it on hand if they do have an acute attack, because you can interrupt it quickly. And so we just manage it on a patient preference basis.
Any other comment?
Yeah, just a general one, I'm sorry. 5 out of 10 questions I get asked in the clinic, the answer is I don't know, okay? And nobody knows. We don't know until we have, as I said before, the hard outcome data. What is the incidence of gout attacks in a low-carb diet or a ketogenic diet? Because low-carb, not so strict. So we don't know, and we should maybe say that out loud, okay?
And I have to emphasize, we're talking patients here. We're not talking epidemiologically. We're not talking. We're talking human beings with psychological needs, with their drivers. So if this patient, I'm not a doctor. It's not my means of treatment to give drugs. But if this patient has seen multiple other advantages to his diet, beyond what we know about him, I don't know, mental clarity that he likes or something like that, and it affects his quality of life, so maybe we should help him go on this diet, because the chance that if he lost weight, he will remain in this weight is bigger than if we switch a diet that is less suitable for his motivational needs. So this is something I really had to add, because we're talking a lot of researcher. I'm all into research. I'm a research nerd, but at the end of the day, it's the patient with his preferences. If this patient comes to me and he says, okay, I have my uric acid rising, but I still but I see a lot of other benefits. I've never lost weight this easy or something like that, because we know ketogenic diet or even low-carb diets lower appetite, then I will not tell him, okay, go on another diet, because this is his preference, this is his motivation and his chance of keeping it that way. I will tell him, go to your doctor and discuss with him the uric acid. I will advise him to drink more. I will advise him maybe temporarily lower the amount of appearance that he gets from his diet, but I will not draw him out, change his diet that easily.
Regarding the uric acid, I totally agree, because I learned nephrology, so I know it's true, and it happens in all diets, actually. It can happen in all diets, not just keto diet. But when the rise is from 6 to 8, which is a major rise in percentages, and it could affect him, there is a major difference between hyperuricemia and gout attacks. It doesn't mean that they have to go together. That's one thing, but the major thing is what happens if it's not 6 to 8. You gave us an easy one. What happens if it's 6 to 10 or 6 to 12? And it remains like this for a long period of time. It's again the same with the cholesterol, with the LDL. I'm not going to get into the argument again. 190 is fine, but if I have a patient with 520 who came last week to the clinic, then the question is more questionable, I think. And what do I have to do with this patient? Because I don't know really how to treat these numbers besides taking, and it was 7 months during the diet, so it came for me for a second opinion. So I think the delta, it's not just rising, it's the delta, it's the meaningful delta of the rise that should make a difference for us as clinicians, whether we're dietitians, physicians, or I don't know who else treats them. So,
But this patient has already gout attack. It's not simply hyperuricemia. He has a gout attack, so it's a complex question because you have to decide whether to give him medicine
or to stop the
or
diet.
to stop the diet.
Exactly. We don't know.
What's the incidence of gout with the ketogenic diet? Can anybody tell me? Oh, okay. I rest my case.
The occurrence of a gouty attack during a ketogenic diet is almost always in patients who have a prior history of gout or family history of gout. For people who don't have that history, I can't recall seeing a case, actually. And, you know, my area under treatment curve now is approaching 10,000 patients. In the 1 or 2% of patients who have a history of gout, probably less than 1 in 10 actually have an attack of gout when we start the diet in an appropriate fashion, meaning we don't start with a period of intense fasting or something of that nature. And it's also not a high-protein diet, which means it's not a high-purine diet. So the cases where we actually have to intervene and treat is quite rare. And I think in the 262 diabetes patients in the Verta study in Indiana, I think we had 1 patient who had an attack of gout in the course of the first year. And that was readily taken care of with colchicine.
Thank you.
We need you here.
There's something I have to say about nutritional interventions. Nutrition studies are notoriously poorly conducted because if it's a short study and you control the food, it's not real life. When you send patients to their natural environment, you usually rely on self-report and food frequency questionnaires, and actually your patients tell you what you want to hear. I'm a big believer in nutrition and keto diets in some cases, but sometimes in my clinic, if I had a polygraph, I'm sure it would explode after one morning. So the beauty of the ketogenic diet, by the way, that it's the only diet that you can actually monitor adherence because you can measure ketones. So since there are such leaders in the field in this room, I think it would be a great idea to do a head-to-head of a ketogenic diet against one good established drug, which we can probably monitor that intervention and see the outcomes for 10 years. That would be a great idea.
Wait, Ram, I want to ask you a question. No, so you opened this for discussion. So I have a patient who is type 1 diabetic on a keto diet, and he has a stomach ache since this morning, and his ketone levels are 2.5, 3, you decide. So where's the data? I mean, I wasn't in your talk, but what's your talk based on? How much data do you have there? Yeah.
I talked about type 1 diabetes. This talk is about weight loss and everything in type 2 diabetes. In type 1, being ketotic on a ketogenic diet is a very unwise strategy. You can go low carb, but you shouldn't be ketotic. That's exactly your question, and I talked about that.
No, but I agree, okay? But you're saying that we have a biomarker to follow in the ketogenic diet, but I'm not sure we do. Because
I'm talking about adherence to the diet.
What?
Adherence to the diet. That's the only thing you can measure with ketones.
And again, I'm not even sure that is true. We don't really know that, okay? We don't have enough data about blood ketones to really understand how they predict a diet in a patient. Maybe he has high ketones because he's insulinopenic in some way and is going, in the wrong direction. And we've seen too many of those patients in our hospital, I'm sad to say, with a ketogenic diet. So we need to validate the biomarker of blood ketones before we can say that it's a good measure of the ketogenic diet, I think,
I'm sorry.
Base a diet.
You're saying that we need to validate whether blood ketones actually measure ketosis? What's the point?
We need to validate whether a blood test for blood ketones actually measures adherence to the diet. You don't know that. Okay, you assume that, but assumption is great. It leads us to terrible places, though, sometimes.
Okay, well, we don't have our patients on SGLT2 inhibitors, which is the only other iatrogenic cause of elevated ketones. Our patient,
No, but some patients can go, maybe a patient is on a ketogenic diet, but...
Can you let me finish, please?
Yes, sir.
We measure ketones in the patients on a daily basis at home. They report them through the app. And at 1 year on the diet, the mean value was 0.4 millimolar. And our quote, threshold, unquote, has been 0.5. And they crossed that at 8 months. So we have clear evidence that out of 200 and something plus people who completed 1 year, that the majority of them remained in nutritional ketosis. And the only way I can conceive that they would maintain that is by maintaining protein in moderation and carbohydrate restriction within a range of 30 to 50 grams per day.
That's not what I'm saying. The fact that you're measuring ketones which are a little higher doesn't mean that the adherence level in patients is the same. That's what the adherence level, you're measuring adherence. When you measure adherence to a pill, you measure 80% consumption, for example, right? But when you're measuring adherence to a diet based on a biomarker, you need to validate that indeed, in every patient who is fully adherent to a ketogenic diet, you will detect a slight increase in ketones. And maybe in some patients, they're very adherent, you won't detect that. And maybe some patients are not fully adherent, and you will detect an increase in ketones. You don't know that. That's what I'm saying.
And we have 100 patient months of inpatient metabolic ward experience with this kind of diet, monitoring ketones and monitoring diet. That gives us a certain data baseline with which to work. And that's published data, papers in JCI and Annals of Internal Medicine, journals like that.
Okay, and now to the gallbladder. We know that is has a key role in the lipid metabolism. So what are you recommended for this patient?
I would be the one that they would probably ask. And I would ask the patient, in the last 3 years, have you found yourself to be fat intolerant? Have there been times when you've eaten enough fat that it's made you sick, caused you acute colic or GI symptoms? And I also worry about fat malabsorption. So if they have fat in the toilet bowl or floating stools, indicating that they would not be able to tolerate the amount of fat necessary to follow a ketogenic diet long term, including the maintenance phase when they would have to eat more than 100 grams of fat per day. Mm-hmm. If the people say no to those things, then we would suggest that the person, if they wish to try such a diet, try it and monitor those symptoms. And if they run into trouble, we back away. If they don't, it could be a very valuable tool for somebody who is severely obese and where typically weight losses are without counting calories and restricting calories, tend to be physiologically significant.
Other comments? Okay. Okay, so we have a lot of more questions, but the debate will go on. Yeah. So thank you very much.
Bright and early.